cells and persist there. We have not been able to substantiate that. But it remains an open question as to whether there are any reservoirs of hepatitis C. But if there were, one would think that it would come back. And even in patients who are transplanted, if you treat them to cure before the transplant, even under the immunosuppression post-transplant, the virus does not seem to come back. So I don't think they're reservoirs. Interesting, we have shown, though, that the virus, when it's there, can attach to lymphocytes. And this just came out in hepatology, and it attaches to lymphocytes through a complement receptor. So this is in chronic carriers. So you now have HCV moving with B cells, and why that is, we don't know, but we're now trying to study what happens inside the B cell once the virus attaches. And is this why you get these B cell syndromes like non-Hodgkin's lymphoma, cryoglobulinemia, Sjogren's disease? Maybe the virus does something to the B cell to foster these kind of syndromes. But I don't think there's a reservoir.
One more sustained viral load. I mean, as it goes with the increase of technology and the limit of detection with the real-time PCRs, it's the limit of detection going down. So the current definition for sustained viral load, would it be 100 IU per ml or viral loads? What would be the current definition for sustained viral load for a patient who is chronically infected with hepatitis C?
I'm not sure I catch that. I mean, you can measure the viral load will go down to undetectable, and you should follow them for a while post-treatment, and that it stays undetectable. But if it remains undetectable by current technology for at least 12 weeks, but preferably 6 months to a year, then I think it's gone. And at least we follow a lot of patients, they do not come back.
With the presentations, I have a question for Professor Thompson. Are there inactivating mutations in the sodium-linked bile salt transporter in the terminal ileum? And if there are, what are the consequences of those? Thanks.
There are extremely rare cases of complete absence of that protein, and those patients have diarrhea. So they have spillover of bile acids into the colon. So they have there's probably actually quite a lot of people out there who have some degree of bile acid malabsorption, and they are presenting with diarrhea-predominant IBS. But the actual patients with mutations, proven mutations, have quite bad diarrhea.
So do they get malabsorption too, or do they compensate by making sufficient bile salts in the hepatocytes?
You can upregulate your bile acid synthesis and cope quite well. And some of the trials we're doing now, we've actually very effectively blocking the bile acid reabsorption protein with the drugs. And it has to be said that surprisingly, we're not seeing fat-soluble vitamin malabsorption and things like that by depleting them of bile salts, by inducing the same process, by blocking that transporter. So I think you can upregulate enough to cope.
Thank you.
And do you use cholestyramine in these cases?
Well, cholestyramine, obviously, in theory, cholestyramine does the same thing. It binds the bile acids and stops them being reabsorbed. In truth, cholestyramine is just not very effective. That's the trouble. So what these drugs, which are now in clinical trials, are actually blocking the transporter, and they are dramatically more effective than the binders.
One more question.
Okay. So thank you. And also I want to ask about the if this one can damage this one, the liver, with hepatitis C, we can give this one medicine for the patient. This is first. And second, the this one very expensive. Is can available in the future, but reduce this costly. Thank you.
I'm sorry, the sound is not carrying very well up here, but
Rituximab, the medication.
did you want to say?
No, I didn't, I'm afraid.
Rituximab,
About the cost of the drugs?
the drugs. Yes.
Yeah, you know, the drugs, you know, it's a difficult equation. You want to encourage pharmaceutical industry to develop drugs. To make those big investments, they need to know they're going to have some big returns at some point. Many drugs fail, so they never recover the money on that. So the drug companies have tried, when they hit a winner, they try to get as much as they can. But in this case, you're dealing with a curative therapy that is being withheld from millions of people. And it's a real ethical dilemma. And I think in this case, you've got to sacrifice huge profits